Welcome back, future Canadian pharmacists. Now, I know the title says 10 herpes virus infections, but for your PEBC exam, we're going to laser focus on the two you'll see all the time in practice, herpes simplex virus and varicella zoster virus. Nailing these is absolutely key, so let's dive right in.
So we're going to kick things off with a question that you could totally see on your exam, or even more likely, get asked in your pharmacy. Keep this question in the back of your mind because by the end of the session, you'll know the answer cold, and more importantly, you'll understand exactly why it's the right answer.
All right, here's our game plan for today. We're going to build a solid foundation, then jump into the nitty-gritty of HSV and VZV. We'll compare our go-to antiviral drugs, and then we'll tackle the super important topics of vaccination and special populations. Every single part is designed to get you ready for the exam.
Okay, let's set the stage. Before we get into specific drugs and doses, there's one big picture concept we need to get straight, and it applies to both HSV and VZV. It all boils down to the patient's immune system. So the very first question you should always ask yourself is, what's my patient's immune status? You know, for an immunocompetent patient, the infection might be pretty straightforward. But in an immunocompromised patient, these viruses can be a whole different beast, way more severe, way more dangerous. And here's the key takeaway. We use the same drugs for both groups, but the dosing, how long we treat, and how aggressive we are, well, that's going to be cranked way up for your immunocompromised patients.
Let's get into our first virus, herpes simplex. We're going to cover the whole spectrum here, from something as common as a cold sore all the way to a life-threatening brain infection, HSV encephalitis.
First step, oral labial HSV, the common cold sore. It's usually caused by HSV1. And here's something important to remember. That very first infection, what we call gingivostomatitis, is often way, way worse than the recurrent flare-ups people get later on.
So what are we actually trying to do with treatment? Well, it's really all about managing the here and now. We want to help with the symptoms of the current outbreak and, for some folks, cut down on how often they pop up. And here's a crucial counseling point. These drugs do not cure the virus. They don't stop it from coming back forever.
Okay, now this is a slide you want to pay attention to. This is a total PBC exam pearl. For those recurrent cold sores, the idea is to hit it hard and fast. I mean, look at valacyclovir, just 1 day of treatment. And famciclovir is even a single dose. Compare that to the old-school acyclovir regimen, 5 times a day. You can see why the newer options are so much more convenient.
All right, let's switch gears to anogenital herpes. This is a super common STI, and it's important to note that while we usually think of HSV2, we're actually seeing more and more first-time genital infections being caused by HSV1. The goals here are a little different. Of course, we still want to manage the symptoms, but there's a huge second piece of this puzzle, preventing transmission to sexual partners. And that really influences our treatment choices, especially when we talk about suppressive therapy.
For a patient's very first episode of genital herpes, we treat for longer, usually about 7 to 10 days. And this is where the better absorption of valacyclovir and famciclovir really makes a difference. That simpler BID or TID dosing makes it so much easier for patients to actually take all their medication compared to the older acyclovir schedule.
Now, for those recurrent episodes, we're back to short-course therapy. The whole idea here is that the patient has a prescription ready to go and they start taking it themselves the second they feel an outbreak coming on. And just look how short these treatments are. Famciclovir is down to a single day.
And here it is, the answer to that question from the very beginning. For patients who need long-term suppressive therapy to cut down on outbreaks and reduce transmission, valacyclovir is the only one that offers that once-daily dosing. That is a massive advantage for adherence and a critical fact you need to know.
Now for the most severe, most dangerous form of HSV, encephalitis. I just want you to look at that number for a second. 70%. That's the mortality rate without treatment. It is absolutely devastating.
But then, look at this. With quick IV acyclovir treatment, we can slash that mortality rate way, way down. This is exactly why a fast diagnosis and starting treatment immediately is so incredibly critical. There's no time to waste.
So here's your exam takeaway. You need to know this inside and out. The drug, IV acyclovir. The dose, 10 milligrams per kilogram every 8 hours. The duration, 21 days. And do not forget that crucial administration detail. Infuse it slowly over at least an hour. That's to prevent acyclovir crystals from building up and damaging the kidneys.
Okay, that's a wrap on HSV. Let's switch gears and talk about our second virus, varicella zoster, the bug that causes both chickenpox and, when it reactivates, shingles.
When we're treating shingles, we've got a few goals in mind. Sure, we want to stop the virus, help the skin heal, and relieve that acute pain. But honestly, the most important long-term goal, the thing we're really trying to prevent, is that awful chronic nerve pain called postherpetic neuralgia, or PHN.
This algorithm is a fantastic clinical tool. The very first question you have to ask is, does this involve the eye? If the answer is yes, that's an immediate referral to ophthalmology, no questions asked. If not, the big decision points are how long the rash has been there. We really want to start treatment within 72 hours and the patient's age. We strongly recommend treatment for anyone over 50 because their risk of getting PHN is so much higher.
So, we've been throwing around the names of these 3 main oral antivirals. Now let's actually put them side by side so we can really lock in the differences.
This table pretty much sums it all up. Acyclovir has really poor oral bioavailability, which is why you have to take it so many times a day. Valacyclovir and famciclovir are what we call prodrugs. They're designed to be absorbed much better, which means higher bioavailability and less frequent dosing. It's why they're usually preferred. And make sure you remember these example rules for each one.
All right, so we've talked a lot about treatment, but what about getting ahead of the problem? Let's talk prevention, which is a huge part of managing these viruses.
When it comes to preventing shingles, there is a clear, hands-down winner. You had the older live vaccine, Zostavax, which was okay, but the newer, non-live recombinant vaccine, Shingrix, is a total game changer. I mean, look at that efficacy, over 90%. And because it's not a live virus, it's the preferred and much safer option, especially for our immunocompromised patients.
Okay, let's wrap up with a really high-yield topic for the PEBC. Special populations. You absolutely have to know how to handle these infections in patients who are pregnant or breastfeeding.
Here is another key exam pro for you. For a pregnant patient who has a history of genital herpes, our #1 goal is to prevent a devastating infection in the newborn. And the way we do that is by starting suppressive acyclovir at 36 weeks of gestation. The data is clear. These drugs are safe in pregnancy, and this strategy works.
And what about breastfeeding? That's a question you're going to get a lot. And you can confidently reassure your patients. This quote is directly from the Canadian Pediatric Society guidelines. It says, the amount of drug that gets into breast milk is tiny, and it's not considered to be clinically significant for the baby. So, to wrap everything up, here's some food for thought. As more and more people get the incredibly effective Shingrix vaccine, how is that going to change our jobs over the next decade? Well, we see far fewer cases of shingles, and more importantly, a lot less of that chronic debilitating nerve pain. It's a really exciting thing to think about for the future of public health. Thanks so much for joining me today.